Okay, guys. So today I'm going to cover this transforaminal technique of endoscopic lumbar discectomy, the lumbar spine. What are the procedure steps to reach your target fragments? In this lecture, I'm going to discuss about only the discectomy part. We are not going to discuss here the stenotic decompression. We have another lecture on that, stenotic decompression, how to do that. So we'll restrict ourselves to only the discectomy part here. Okay. In between, if you have any query, you can ask me anytime. You can stop me and you can ask me. I would suggest to keep your videos on so that I can make out that you guys are understanding something, or maybe you're not understanding, so that I can go slow, or maybe I can repeat. That will be only possible if I see your faces. Otherwise, it will be like a one-sided lecture only. So try to keep your videos on. Keep yourself mute. Whenever you have any question, you can just unmute yourself and you can ask me. You don't have to take a permission for that. Okay. All right. Okay. Ajay, I'm muting you because there's a lot of distance there. Okay. All right, guys. So, so if you remember, we discussed about the anatomy of the spine. We discussed about the uh, uh, multiple tissues which we cross to reach our target, that is the foramen, and how to reach the disc. So we discussed the anatomy part of that and what all important structures are there in between, and what are important structures which we should avoid going into that area, like peritoneal area and other vascular areas, and what all painful areas are there in between when we reach our target, what all painful tissues are there which we have to anesthetize so that we can have a very good uh, procedure only under local anesthesia. There are multiple ways of doing it. Uh, what I'm going to show you is the simplest way. Uh, so if you go to other workshops also, you may be able to see that people are doing in a different manner, but ultimately that target is all the fragment, how to reach that fragment. So that is the most important, and what are the procedure steps that we are going to discuss today. Okay. All right. So we already discussed about the anatomy of the foramen, and we know this is the area where we had to go because we are talking about a transforaminal endoscopic lumbar discectomy, TLD. So for that, the foramen is important, and we have to uh, uh, reach our target fragment, whether it is inside or outside, or in the within the foramen, or it is outside the foramen, whether inside the canal, it is migrated upwards or it is migrated downwards. Whatever it is, we have to go through this foramen. Okay, and the relation of this foramen is important. So I'll just briefly cover it here. Although we have covered everything in detail, a lot of details we have discussed in detail about the foramen anatomy. So here you can see this is a foramen over here. So this is a infrapedicular notch. This is a suprapedicular notch over here. This part, the anterior border, is having the bony margins over here and here. And in between we have a disc over here. So disc is mostly in the lower part of the foramen. Lower part of the foramen. If you divide it into two parts, the disc is in the lower part of the foramen. Okay. And we have some important structures over here. The exiting root are there, and we have some radicular arteries over there. Okay. And posteriorly we have the facet joint. The facet joint, inferior articular process and the superior articular process. Okay. So whenever we go through this through the foramen, we also have to check the size of the foramen, and that is only possible if you take a X-ray, lateral X-ray. In that we can see exactly the size of the foramen also, whether we need to open the foramen with the foramenotomy or not. That we can see with the see on the X-rays. So it's a good idea to definitely MRI is must. MRI is must because that will show you where is the fragment lying, okay, whether it is migrated upwards, downwards, which nerve it is compressing, whether it is exiting route, traversing route, or it's compressing the entire thecal sac, one-sided or both sided. So that for the MRI is the must. So we have to have MRI. Along with that, if we have X-ray, that is also good because although we are going to do under fluoroscopy guidance, initial steps are under fluoroscopy guidance. But just to avoid any surprises in the operation theater, if you have X-ray with you, that is also a good advantage to you. Especially if whenever you are suspecting any lumbaration or sacralization, especially the sacration of the L5 vertebra, that time it is always good to go for the X-ray, and especially when if we have also have some degenerative conditions which are visible on the MRIs, if you can see the facetal hypertrophies over there, in those cases again it is good to have a X-ray so that you can plan your entry according to that, and you can be prepared to open the foramen with the biforaminectomy. So as so the first thing which comes into the mind is that we everything is under fluoroscopy guidance. Initial few steps are under fluoroscopy guidance. Under fluoroscopy guidance, we know the limitation of the fluoroscopy is that it's a two-dimensional image, what we see on the fluoroscope, right? So many times we had to imagine many things. We had to be very, very thorough in our anatomy because uh, what we see on the fluoroscope is actually what we cannot see on the fluoroscope is actually there. Okay, and there are many things which we see very clearly on the fluoroscope, but they are actually behind some other bony tissues. Before reaching that area, we had to cross other tissues also. So it is important to have the good anatomical knowledge, also the fluoroscopic anatomy knowledge. Uh, Another important thing is that we go in a different direction, like a patient lies in a prone position, C-arm is in the AP position, and we are going from the posterior lateral side. We go from the posterior lateral side. So this angulation is important because so it all depends on the level, at what level we are doing. So this we discussed in the anatomy lecture. It is everywhere, it is not same. Another, once again, I'll repeat the same thing which we discussed in the anatomy lecture also. Don't go by the centimeters, don't go by the degrees. Don't make it a fixed idea about the degrees and the centimeter. Lot of times you'll see that some people they teach like this, that L5 S1 go 12 centimeter, 4 5 go 8 10 centimeter, 3 4 go at 8 centimeter. This is not applicable. It all depends on the upon the multiple factors which are to take into consideration. Those who have attended the workshop, we had a good discussion for almost 3 days on this. Uh, so I showed them how much difference it makes if you're doing something at alpha S1 or if you're doing something at L2, L3. It makes a lot of difference. Okay, so there should not be any fixed criteria for that. Don't go by the fixed criteria of degree and a centimeter from the midline. Are you getting my point?
Yes, sir.
Okay, great. So if you look at this anatomy, I'll just once again just briefly cover it over here. So if you look at here, you can see here, see the facet where the facets are lying in the at the L5 S1 area, right? And as we go upwards, look at this. Okay, so this is what is happening here. Can you see here? The facets are more horizontal over here at the L5 S1 level. As we go upwards, the lamina is shorter. Here you can see this interpedicular distance. Look at the interpedicular distance over here. Okay, so it is like this. Okay, so what may be true for alpha S1 is not true for the L2, L3 or L3, L4. Okay, the angulation, the distance from the midline will change from level to level. That is one. That is the same person. Second is the patient's structure, the weight of the patient, the post this thing, the subcutaneous fat, okay, the muscle mass, all these makes a lot of difference. Okay, so you have to take into consideration all these important points before we decide for the whether we want to go for the inside out, outside in, or whatever it is that we'll discuss later. Okay, understood?
Yes, sir.
So you can
Yes, sir.
look at here at L1, L2 level. You can see this is the one of the major difference. Like the suprapedicular notch is quite deep. As you go down towards L4, L5, L5 is 1, this notch has become shallow. Okay, this one difference we saw it here, that as we go upwards, the facets start going towards more medially because of the interpedicular distance is also here it is less. Okay, we start going more medially. Okay, also there's another difference is that uh, the the cortical wall here, okay, the posterior cortical wall is more concave in the upper lumbar vertebrae. As you start going down, the concavity starts going down and it becomes almost flat at L5 or S1 level. Okay. So the first thing which comes into the mind is that whether we should go for the inside out or the outside in techniques. So I think Dr. Datta already explained about that. What is inside out and outside in techniques? I'll just cover it once again here. So this is just a um, broad broadly I'm telling you that in which case we should select the inside out and outside in technique, and firstly what is inside out and what is outside in technique. As the name suggests, inside out technique means we had to go first inside the disc, we start clearing it over there, we start coming out, and then we clear the rest of the space on the cranial the intra spinal space. That means initially our placement of the needle, our dilator, and also your working channel, we place them inside directly. This is one of the safest technique, but it has a lot of limitations. The most important limitation with this technique is you may not be able to clear the fragment. Our target is fragment. Okay, our target is fragment which has come out. So if you have extruded this, if you have extruded this, if you start going for the inside out technique, inside technique, in that case we may be able to take out some good material from here, but that is not sufficient. Okay, you start coming out and you come out of this and your fragment will be lying over there only in the canal. Okay, so that is the biggest limitation of the inside out technique. Okay, especially if you have a narrow foramen. In that case, it is difficult to manipulate your working channel into the foramen, through the foramen. So once you go out, it is difficult to change the direction to see the the spinal canal. Okay, so if you have this condition like this, if you see that it's a diffuse bulge compressing the nerve roots over here, then it's a good idea that you can go for the inside technique. We start going from here and then start going inside. But here also, I would like to warn here is that if you see such diffuse, huge bulge, and if you see on the MRI that the compression of the nerve is severe, in that case, don't go directly inside, because once you go inside, we put a dilator inside. Once you put a sheath inside, that will compress your nerve, which is already compromised. Okay, so you may damage the nerve at the time of entry only. You may not be directly hitting the nerve, but by because whatever you are putting inside is going to take some space, right? And if the canal is already compromised or the nerve root is already compromised, and in that also you are putting some working channel inside, that will further compress the nerve, and you may be doing your job over here, and this nerve is compressed for longer time, and you may have some loss of the sensation at the end of the procedure. Okay, so in such cases, if you see such a severe compression is there, it is always better to start decompressing it from here, start going gradually inside, create some space over here, and then start going inside and start decompressing it from there. Okay, just create a space over here and start putting your this thing the grasper inside and decompress it from there, so that you once you create some space inside, then you can go easily, so that you already have some space here, you have created some space for the nerve. Is that point clear?
Yes, sir. Sir, I have a question.
Yes.
Sir, if
Who
the
is this?
broad base prolapse disc
Who is this?
is a chronic one, which might have calcification,
Ah,
probably I couldn't diagnose at the time of before operation.
ah.
Then inside out technique, will it works uh, as a decompression operation?
So very good question. Um, who is this? Najib. Najibul.
Yes, sir.
Najibul.
Yes, sir.
Yeah,
Yes, sir.
Najibul. This is really good question. So even on MRI, we can see this calcified disc. It's
Yes,
not
sir.
necessary that you should have a CT scan for that.
Yes, sir.
Uh, and I think in the MRI, in the first lecture, I think I showed you that calcified disc also.
Yes, sir.
Got
Yes,
it,
sir.
है ना?
You show us.
So
Yes, sir.
yeah, so in that what happens that if you see that annulus is thickened over there, you will see it's like a thickened annulus. Okay, and it is
Yes,
compared to other part of the annulus, it is slightly darker. Okay, then you
yes,
can
sir.
make out that it is a calcified annulus or calcified fragment over there.
Yes, sir.
Now your question is that whether we can remove it or not. Actually, it becomes easy if it is a calcified. So what
Yes,
happens?
sir.
That suppose there's a calcified fragment over here, over here. So what happens then when you go inside? At times, you when you catch this fragment, this come as a one single immediately. It comes out. Okay,
Okay, sir. Okay,
but
sir.
that is not always possible. At so what will happen is that once you go inside, when you start removing the disc material, you just see the consistency of the fragment. The consistency will be, it will not be dark, it will not be black outside, or it will not be white, which is visible on the CT scan. It will be like a very bright structure. On MRI, it will be very dark structure, right?
Yes, sir.
But when it
Yes, sir.
comes out,
You
it will,
told previously.
huh?
Yes, sir. You have mentioned in your first lecture,
Yes,
the calcified one is very in MRI is darker.
yeah. And when we take it out, you will see it like a slightly yellowish brownish color of fragment, and slightly harder as compared to other disc material.
Okay, sir.
Okay.
Okay, sir.
So
Thank you, sir.
in that case, you can, yes, definitely you can go inside and you can start extracting it from there also, from inside also. That is very much possible. Okay.
Okay, sir.
So this is one where we can go inside and we can start extracting the material from here, because there's a diffuse. You can see there's a diffuse bulge over here. Okay. In this case, you can go inside and you can start extracting from here. That is safer technique. Safer technique, especially in such cases where we don't have to go and open the entire space over here. But if you see this material like this, extruded completely outside, okay, in such cases, it is better to keep it outside. There's no point of going inside here. Okay, you may not be able to extract this one. Okay, so in this case, it is better to go over here into the foramen, start clearing the foramen, and then start going inside. Okay, so that is a better technique. Or maybe at times, what is required in such cases is a half in, half out. In fact, most of the time, when we say outside in technique, it is a half in, half out technique only. Okay, what happens that in many cases, in many cases, you'll have to go inside, even if it is lying, it is extruded outside, but the tail of this fragment is inside. Okay, I'll show you how this looks. Suppose it is like this. Okay, the disc material is here like this. Okay, so what happens that you'll be able to appreciate this, that the annulus is there. There's a big breach in the annulus in the axial section, and you can see that the disc material has come out and it has left a tail inside over here. So in such cases, obviously our target is this fragment. Okay, but what we can do, we can go inside, we can go outside only, not inside. We can go just outside only. They change the layout or what? So our target is definitely this one fragment over here. Okay, but at times what we can do is we can go inside over here like this, not like this, not like this, but from here, that is closer to the extruded fragment, we can enter the disc over here. Okay, we can at times we may have to make a anerotomy also over here, anerotomy over here, and then reach this fragment. Okay, so if you see such kind of fragments on MRI, if it is not completely extruded, it is better to go inside and we can start extruding from here and it will come out, it will bring this back here inside. And you can remove this. I'll show you some videos where you will be able to appreciate that. Okay, so this is actually called a half in, half out technique. We are outside, but once we reach the fragment side, that time we are just making a small anatomy and we are going inside and extracting this material from there. That is called half in, half out technique. Is this point clear?
Yes, sir.
Any doubt to anyone?
It's 20 hours.
Okay. Now look at this. Now can you see this? What will you do in this case?
Obviously, sir, this I can extrude it through inside out technique.
Wonderful.
The first one, the first
Very,
one. The
very
second one, I should go half in half
good.
outside. We can do this.
In this case, you may not require any half an hour because if you see here,
Oh, yes, sir.
there's a
The outside in technique.
basically we have to go inside and we can start seeing, looking at it over here, and we can extrude, take out from here also. Okay, we don't have to go inside in this case because there's hardly anything, any tail over there, because this
Okay,
portion
okay.
is bigger, right?
Yes, sir.
Portion is bigger. Okay, so you will be able to extract it from here only. Okay, and this one,
And third one, obviously it should done in outside in technique.
yes. So, but outside in, but if it is migrated somewhere, in that case, it becomes difficult. Okay, so we'll have to take a call on this. Such kind of sequestrated disk. In this case, we'll have to take a call where the fragment is lying, whether it has gone upward, downwards, right? Most of these sequestrated one, they migrate. Okay, they migrate either upwards or downwards. Now, how far they have migrated upward and downward, whether we can reach there safely or not through the foramen, that we have to decide. Okay, if it has migrated too much upward or downwards, in that case, it is better to go for the interlaminar technique. Okay, interlaminar.
Okay, sir. Okay.
Okay, all right. So in this case, obviously, so the first thing which a lot of people ask is that I was expecting that somebody will ask this. Ki, once the annulus is intact, why would want to go for the endoscopic in this patient? Okay, they are making a hole in the annulus, right? They are making a hole in the annulus. But if the fragment is big, if it is compressing the nerve, in that case, we have to remove this extruded material, the contained material. But we will go for the inside out technique in this case. Why? Because if we go and target this extruded this material from outside, what will happen? Suppose if the ideal is that we should go inside like this, okay, and start extracting from here, okay. But some may say that why not like this?
Uh, if we go outside in techniques, then we will iatrogenically tear the annulus at the foraminal level.
Yes,
That will produce some sort of
yes,
again chance of any herniation or something like that, sir.
very true, very true. Because if you want to target it from here, from this point, we have to cut this entire annulus to reach this material, right? So we are making a big rent into the annulus. But if you go inside out, we are just going with the dilator, with the scope, and we'll come back and it will retract over there. But here we'll have to cut the annulus, right? If you target this one,
Yes, sir.
then we'll have to cut the entire annulus over here. So we don't want to do that. We are making it more vulnerable for the reherniations. Okay, so that is the one reason why we should not target this from here. Okay, good. I hope all of you are getting these points, understanding what we are talking. Guys, at least
Yes,
say
sir.
something. I'm talking to these guys. Nobody's responding. Okay, I'm going to stop this video, video recording. If you think that you are getting video, so we'll not discuss, I'll stop recording. You need to discuss this.
Understand, sir.
Okay, so this also we discuss about the different types of herniations which are there. Don't send it on chat box. I need to open it again once again and again. You can just unmute yourself and you can just tell me. Okay. Okay, so this is basically the type of the herniation. So our entry, the distance from the midline, our angulation, everything will depend on the type of the herniation. Which side is the herniation? Where is the herniation? Okay, whether it is central herniation, whether it's uh, a paracentral herniation, which is also called a um, facetal or the articular, subarticular herniation, or it's a foraminal herniation, or it is a extraforaminal herniation. So depending on that, we have to select our entry point, our angulation, distance from the midline. Okay. So if you look at this, so what is this? What kind of herniation is this?
Extraforaminal.
Extraforaminal.
Very good. This one?
Foraminal.
Foraminal.
Very good. This one?
Paracentral.
Paracentral or
Paracentral.
yeah, it is also called subarticular. You know? This is also called subarticular. This point, right? Here.
Yes, sir.
Okay, this is also called subarticular or the paracentral herniation. Okay, and this one is
Central.
Central.
central herniation. Okay, so on this model, we can understand that somewhere herniation is somewhere here. That is central,
Herniation.
right? Something here is the
Yes,
central.
sir.
Okay, something which is here, the central one. Okay, something which is here,
Paracentral.
paracentral or subarticular. At the pedicle level,
Foraminal.
foraminal, and outside that,
Extraforaminal.
Extraforaminal.
yes. So now you can make out that angulation will change. Our entry point will change, right? We cannot have the same entry point. We cannot have the same distance from the midline for each kind of herniation. Okay.
Yes, sir.
Now, what is if you have to go for the extraforaminal? Let's say extraforaminal. What is the angulation which is required? Whether it is a vertical or it's more horizontal.
More vertical.
More horizontal.
Horizontal.
Like this
Yes.
or like this.
Yes, sir.
More
No, sir.
horizontal.
More
Second one, sir.
horizontal.
Or vertical, sir.
More vertical.
Very good. Excellent. Vertical. You may say it looks like, oh my God, it is lying over here. Why not to go like this and remove this from here? Right? What is so big deal in this? We can go straight over here, okay, more horizontal, and straight away go and hit it and remove it from here. But what is the most important structure here?
Peritoneal.
Huh?
Peritoneum.
No, peritoneum is far ahead. At this level, we can go safely in this. We can go like this. We can safely go. See, look at this. The peritoneum is somewhere here. We can go safely here. If it is extraforaminal. The biggest issue is you have a, what is this?
Ganglion.
Root. Your exiting route is there,
Exiting route.
node. Exiting node.
right? Your exiting route is lying there. If you go directly over there with just dilator and a sleeve, you will definitely hit the exiting route. You will damage the exiting route. Understood?
Okay,
Yes,
sir.
sir.
So, sir, if we go more vertical, it will
Yes.
hit the transverse process, isn't it, sir?
No. Transfer process will not hit. You know, see, we are going here. Transfer process is here. Look at this.
Yes.
The disc is
Oh,
here.
yeah. Okay, sir. Okay, sir.
Okay. No, not through the transfer process. This is just a model. I'm just showing. I just make this angulation like this so that you can understand. It is see inside body. It is
Yes.
not like this, right? It is not like this. It is like this, right? Sorry, this is basically the model which I'm showing here. I just angulated it slightly downwards like that, just to make you understand. That's it. Okay. But otherwise, it is like this, right? So we are going over here. Extraforaminal is somewhere here.
Yes, sir.
Okay. So we have to go more vertical. That means if you look at this pedicle, can you see the pedicle? Can you see the pedicle
Yes,
here?
sir. Yes, sir.
So
Yes,
pedicle.
sir.
Now this is another important terminology which we discuss in the anatomy lecture also. That there's basically it's a lateral pedicular wall, the mid pedicular line, and a medial pedicular line. These
Medial
are important, right?
Yes, sir.
So in this case, we are keeping it outside the pedicle, lateral pedicular wall. So the lateral pedicular line. See this? That's a lateral
Yes.
pedicular line, right?
Yes,
So
sir.
we have to keep it outside that because we are not targeting to go inside. For that, we had to go target a mid pedicular line or a medial pedicular line, depending on the herniation also. Okay. So remember simple things here in relation to the pedicle. In relation to the pedicle. Okay. So this is the most important point, because your entry, your angulation, okay, that is going to decide the success of your endoscopic discectomy. Okay, understood this point? And that is
Understood,
only
sir.
possible. That is only possible if you know thoroughly your MRI where is the fragment lying. If you read your MRI properly and then start doing endoscopic procedure, if you have your patient with you, you have your MRI with you, read it properly, see it properly, and then plan accordingly. This I'll keep repeating because there are a lot of wrong teachings going on everywhere. Everywhere they just tell you for L4, L5 go at this centimeter, L5 is 1 go at this centimeter, that's it. That is not correct. Don't go by that. Okay, it all depends on the type of the herniations and the level also, what level you are doing. Okay, so in this case, what is important is that before we enter our needle, the first thing is what we would put as a needle, right? First thing,
Yes, sir.
is the needle, right? First
Yes,
you
sir.
Yes, sir.
So when you put a needle in the lateral view, our needle should enter the disc, okay? In the lateral view, it should enter the disc, and in the AP view, it should be just at the outside the
Lateral pedicular line.
line.
At the,
Good. Okay. So that is why it is important when you do endoscopic, if you have seen cases, when we do go in the AP view, then we have to check lateral also. Where is our needle tip, right? That is very important step. Very, very important step. Okay. So in this case, we'll have to keep it outside the pedicle line. So suppose it is foraminal herniation. Suppose it is foraminal herniation. What we'll do in that case?
More horizontal.
Yes. Will it change?
More horizontal.
Yes. Okay. But our needle should enter the disc at what level? At the lateral pedicular line. Okay. Not at the mid pedicular line or the medial pedicular line. Otherwise, what will happen? If you go too much like this, what will happen? You'll miss the fragment. You'll miss your fragment, right? You because you can't see the fragment till the time you put a scope. Okay, you can't see on the fluoroscope. You will put a needle inside. You'll put the guide wire, your guide wire inside. You put a dilator inside. You put a scope inside. Now already this behind your working channel, this fragment is lying there, and you are searching this fragment here somewhere here. Is that clear?
yes, sir.
Yes,
Yes,
sir.
sir.
So what we'll do is we'll just keep it at the lateral pedicular line. We'll enter. We'll put our scope here, and we'll start searching it in the foramen itself. Because now your scope is looking here, right? When you go inside, your scope is looking here. Okay, so you start searching it in the foramen itself. Okay, before that, you must understand that the importance of superior articular process. Because when you're going inside, you don't know under fluoroscopy, you don't know how deep you are going. So you must hit the SAP first. Hit the SAP
Yes.
first.
Yes, sir.
Then
Then we'll
change the
sleep.
direction. Then change the direction wherever you want to go. Okay. So if you want to go into this part, after hitting the SAP, we look at the lateral view. Okay. In the lateral view, suppose if you are hitting somewhere here, Okay. Then you need to walk off the SAP. Okay. And then you can change the direction and you can go to the lateral pedicular line. Now suppose your target is this one. What do you do? Where your needle should enter? After hitting
More
the
horizontal.
SAP, after hitting the SAP,
A
walk
particular.
off SAP and enter the disc. When I say enter the disc means needle only. I'm not talking about the scope and other thing. Right? Because with the needle you have to
Yes,
enter
sir.
the disc. With the needle you have to enter the disc. Because over that you'll put a guide wire. Okay, you'll do some discogram also that you insert
Yes.
it. For that you require that. That doesn't mean you have to put a scope also inside a disc. And when I'm talking about a enter the disc means I'm talking only about a needle part. Okay, you enter the disc.
Understood, sir.
So your entry inside a disc is at mid pedicular line. Now you put a guide wire inside. You put a guide wire inside. You put a dilator over here. Now here you don't have to make a puncture here. Okay, you put a dilator. You put a working channel over here. Now your working channel is over here into the foramen. And what you're seeing is inside the canal because it's a 30-degree angulation. Is it clear?
Yes, sir.
Yes, sir. Clear.
But if a target is now central part, in this case, maybe you have to go far lateral. Okay, far lateral means maybe you have to enter after hitting the SAP, you walk off the SAP and enter the disc at the mid pedicular line,
Me.
medial pedicular line,
Particular.
medial pedicular line.
Okay, sir.
Okay, understood? So you have to enter the disc at the medial pedicular line. Now here you have to be careful
Yes, sir.
because if you miss your middle pedicular line and if you missed your middle pedicular line, let's say if you miss your middle pedicular line and you keep going inside like this under the SAP, what will happen? What is the important structure here?
Exiting nerve root can be
Sir,
Traversing.
traversing nerve
Traversing
nerve
here.
root is here.
Yeah.
Traversing root
Traversing
might be
root is here. Your
injured.
sac is here, right? So
yes, sir.
you have to check lateral that you are entering the disc at in the AP view. Once you reach the medial pedicular line, in the lateral view, you should see that you have entered the disc. Point clear?
Yes.
Yes, sir. Sir, I have a question, sir.
Yes.
Sir, if I go, suppose I have a central disc herniation. So can I just go at the lateral pedicular line? Then I place my scope over there and gradually go inside, looking after the central disc, and then I just remove the central disc. Is it possible? So
See,
outside in technique.
so that is actually what you are going to do. As I just mentioned that I am talking about a needle only, right?
Oh,
You're putting
sorry,
the
sir.
needle
Sorry,
inside.
sir. Sorry, sir.
We are not putting our scope inside. Okay, this is just for the needle entry so that you have a direction. Now in this direction you have to put a dilator, everything. Okay, because now once you put a guide wire, because needle will tell you where to go. The final is whatever needle placement you have done inside a disc, that will give a direction of the entire everything. Now it's your wish. You want to keep it here, you want to keep it here, wherever you want. You have leverage. You can move it up and down once you reach the foramen. And that is what you do. Okay? You don't go directly inside a canal with this big scope, right? With the working channel. You don't go directly inside. You always keep it in the foramen. You start clearing the foramen, you see the structures over there, and then start going inside.
Okay,
Okay.
sir.
Understood? So that is why again I'll repeat the same thing. Whatever we are discussing here, we are talking only about a needle entry, because that is going to give you direction. Everything
Okay,
will
sir.
depend on that. Okay? Understood?
Yes,
Yes,
sir.
sir.
Yes, sir.
So this is the most important. Now look at this. Now we have gone far lateral, right? Okay. So far lateral, another guidance for the far lateral is that now you may say that if I go too far lateral, I may enter into the peritoneum. I may beat the peritoneum. I don't know. Okay. How far to go? Okay. For that, the best guidance is your spinous process. Check lateral. Check lateral. Okay. In the fluoroscope, you can see the spinous process here.
Yes, sir.
Yes, sir.
You can see the spinous process right here.
Hmm.
Okay.
Yes.
So you put a marker over there. You put a marker over here. Okay. Now look at over the skin where this point corresponds with the tip of the spinous process. That means here, this point over the skin. Okay. So this much far lateral you can go. Understood this point?
Please repeat, sir.
So what you have to do is forget about this. You check lateral. You see the lateral view. Can you see the lateral view here?
Yes.
Yes, sir.
Yes, yes, sir.
Put a marker over here. Put a metal marker over the skin.
From lateral view, sir.
Huh?
Lateral.
Lateral. In the lateral view, you put a marker over the skin, a metal marker. Metal marker.
Yes.
Or a guide wire can also.
Huh?
In the lateral position, we can just hold a guide wire or something.
Whatever metal,
That,
any metal, yes.
yes,
Any metal,
metal.
any
Yes, sir.
needle, whatever. Guide wire, needle, whatever.
Yes, sir.
Metal marker, put a metal marker there, and then make a point over there, over the skin. Okay. So this much far lateral you can go. So that means it will correspond. Suppose this is the patient's body. Suppose this is a patient. Sorry. They made some changes into this. For what is happening? Draw. Okay. Okay. All right. Okay. So in this case, what will happen? There is a subcutaneous fat over here,
Yes.
Ligament, the ligament is there, right? So
Hmm.
now this will correspond to now over the skin. When you check in the lateral view, you're checking the lateral view. This comes over here. Let's say here. This is actually wrong. This is going like more vertical. The body will be
Yes,
like
sir.
this actually. The body will be like this. Anyway, this is wrong diagram. Body is like this. So here somewhere it will correspond to that. Like this. Understood now?
Yes, sir.
Yes.
Yes, sir. Yes, sir.
So over the skin, you check the lateral view. You see the lateral view. You're seeing it from here, right? This is the abdominal part, patient's abdominal part here. Abdomen is here. Okay. You see the lateral view. Now you put a marker over here, over the skin of the patient, and put a point that this is my far lateral approach. I can go this much away from the midline. Now you can clearly make out this distance. Can you make out this distance? Will this be constant in all the patients? Is it possible?
No.
No.
Right? A patient who is less bulky, a thin patient, okay, maybe it is the distance may be this much, right? It all depends on the patient to patient.
Mm.
So don't go by the fixed centimeters and just fixed degrees.
Okay.
So the point is we insert our needle at the most prominent point of the spinous process, sir.
The tip of the spinous process. The tip of the spinous process, yes.
The most prominent. Okay.
The tip of the spinous process, yes, here.
Okay, sir.
Okay.
Yes, sir.
If you go more lateral, somewhere here, okay, there are good chances that you may enter the peritoneum. Okay, clear?
Yes, sir.
Yes, sir. Understood.
Yes, sir.
Yes, sir.
Now look at this. Now look at this MRI here. Can you see this fragment here? Can you see the fragment here?
Sir. Yes, sir.
Okay.
Yes.
Now suppose
Yes.
you want to target this fragment, where you should enter the disc.
Uh, at the mid pedicular line.
Yes. So somewhere here.
Yes, sir.
Okay. Somewhere here. Okay. And why it is important to hit the SAP always? Now suppose if you are going like
To
this.
avoid the exiting nerve root.
Yes, wonderful. Suppose if you are going like this, we don't know we are superficial or we are deep. We don't know we are superficial or deep. If you are superficial, no issue, no problem. Okay. What will happen? If you are superficial, what will happen? Once we reach the facet joint and we are not still hitting the bone. We are not still hitting the bone. That means, what does that mean? If you are not hitting the SAP, and you're not hitting and on still joining. Okay. Suppose I'm going like this under fluoroscopy. Okay. Now here I should be hitting the SAP. I should be hitting the bone.
Yeah.
Right. Now in the AP view, I see that let me show it on here. Let me show it here. I'm going like this. Sorry. I'm coming like this. Okay. Now at this point, I should be hitting the SAP. Right?
Yes.
Yes, sir.
Yeah.
Now suppose,
Yes, sir.
suppose I reach here and I'm still not hitting the SAP. Now look at this scenario.
Oh.
I've already reached here and I'm not hitting the SAP. What are the possibilities?
Probably we are in at the foramen, yes, sir.
Okay.
Or in
Yes.
more superficial.
Huh?
Or
Yes. Correct. Wonderful. So there are two possibilities. One is that either I am too deep, right?
yes, sir.
I'm too deep, right? Or I'm too superficial.
Yes, sir.
In both the cases, I am crossing the SAP on the fluoroscope, I'm crossing the SAP, but I'm not hitting the bone. I am still in the soft tissue. That means either I'm too superficial or I'm too deep. If you're superficial, no issue. You check lateral, you see that you're superficial, your needle is here, your disc is here, you are here. That means you're too superficial. You come out, change the direction, and you can go here like this. But if you're too deep, what will happen? What is here?
Exiting the
Exiting nerve roots.
Exiting
Yes.
nerve.
You have an exiting root over there. Okay, you may hit the exiting root here before you reach here. Okay, the third possibility is you are directly going inside the foramen. That is again, you are deep. Okay,
yes, yes,
Yes, sir.
so it is always good to hit the SAP first. Then the SAP also, there are possibility when you check in the lateral view, you may be hitting the superficial part, you may be hitting the middle part, or you may be hitting the lower part, whatever. But in the lateral view, when you see you are too superficial, you are the upper part of the facet over here, you know that I have to change a good direction to hit the lower part. Right? If you're already hitting the lower part, you know that now I just have to walk off the bone. Okay? So lateral view, always keep checking lateral view. Once you hit the SAP, if you are not hitting the SAP, still you have to check. If you're not hitting the SAP, once you hit the SAP, again check that which part of the SAP you are hitting. Superficial, middle, or deeper part, lower part. Is that clear?
yes, sir.
Yes, sir. Yes.
Good. I think those who have attended this workshop, I told them about the tricks about this. If you remember, whoever attended to this, normally what I do is I go with the 20 gauge needle for the local. That will give me the direction also. Okay. And that will avoid some major injuries also. So I go with the first 20 gauge needle. I'll go inside. I'll do the same technique. Everything I'll do the same like our puncture needle. Only thing is I use first 20 gauge needle to locate my entry point, to locate my disc, to locate my SAP, disc, everything. With that needle, the dual advantage is that one thing is that you are going with a smaller needle, smaller diameter needle. And second advantage is that you are anesthetizing the entire segment from annulus to the skin. You anesthetize with that. And you get a direction sense also. And then you go with this your 18 gauge introducer needle. Okay, got this point? This is clear.
Yes, sir.
Okay.
Yes, sir.
Yes, sir.
It will all depend on the patient to patient and also from the level to level also. So this is again I show you on this so that you can understand. So this is SAP over here. Okay. So look at this. Now can you see the skin over here?
Yes,
Okay.
Yes,
yes,
sir.
So if you want to go for the extraforaminal herniation, you can go like this. Go like this. Over here. Okay. Going to go for the foraminal. Go like this. Little pedicular wall. Little pedicular. Okay. It will be somewhere here. The foraminal one. Bit pedicular. And if you want to go into the for the central herniation, then you have to go at the left somewhere here. Far lateral here. Okay. Now look at this. Can you see the spinous process here?
Yes, sir.
Yes, sir. Yes, sir.
Actually, you can measure your distance looking at the herniation here. You can actually see the distance from the MRI also. You can plan it beforehand also by measuring the distance from the midline. Suppose if you want to go palatal, if you want to target a central one, you can see the distance from the spinous process and you can measure this distance over the skin, spinous process to this. You can measure this distance and you can plan accordingly. Okay. See this distance from the midline. Look at this distance from the midline. Okay. Or this distance from the midline. So you can plan beforehand also before you take the patient inside OT by just looking at the MRI. Okay, this is the angulation I want. This is the angulation I want. I want to target this fragment of this fragment, and I can go from here and I can target this fragment. And I can measure, you can measure it from the midline. You can measure it from the midline on the MRI itself. Okay, understood? But what is
Yes,
important?
sir.
What is important is that you have to have this complete axial section. If it is not there, you cannot measure. Okay, you have to have this complete axial section with you. The deciding on the MRI, you have to do that because that will also tell you about the fragment. So whenever you have this foraminal herniation or the paracentral herniation, in that case, what happens? What will happen to this dura?
Dura is pushed.
Yes.
Uh,
So suppose it is like this. Okay. So dura is already pushed over here. So you have a good room to enter inside. Okay. So now you know you have a good margin here. Here I do not have any dura. I do not have any traversing route here. Okay.
Yes, sir.
It will also give you some confidence. Yes, there is nothing inside here. This part is filled with the nucleus material, with the extruded material. Because my dura is pushed here. Okay.
Yes, sir.
Yes, sir. Understood.
This will also help you in deciding the side also. Deciding the side also. Okay. At times this may happen. This may happen that patient is having central herniation. It's not always necessary. Remember this. It's not always necessary. You must have seen in your clinical practice also. It's not always necessary that central herniation means central only. It is not always that. Usually the central one is like this, extending up to the lateral recess, or this one is extending to the foramen also. So it's a combination. Okay. Not always that you'll have only central herniation or the only paracentral herniation. Okay. This may extend into the foramen also. Suppose they extend into the foramen. So again, what you'll do? You'll go to the foramen, start clearing it from there. Any doubt? Now this is what I was telling you. Now look at this. This is at L2, L3 level. Okay. See the
Okay, sir.
angulation here. Look at the angulation here. And look at the angulation here. They are almost both are same. Okay.
Yes, sir.
With this angulation, we are into the canal. Can you see that? Your sleeve is inside a canal.
Yes, sir.
Yes, sir.
Okay. Whereas at L5 level, the same angulation, you are inside the disc.
Yes.
Okay. So if you have to target a fragment, suppose if you have to target a fragment which is parasternal over here or subarticular over here, this angulation, this vertical angulation will be sufficient for L2, L3 level, but this is not sufficient for L5, S1 or L4, L5 level. If you go that steep inside, you may enter the disc. You will miss your fragment over here. For this to go into, you have to go more horizontal. That means more horizontal means more distance from the midline. Understood? And you can
Yes.
clearly see,
Yes, sir.
and you can clearly see it from here. Look at this. Can you see the disc here? You can't.
No.
See, can you see the
No,
disc
sir.
here? Can you make out some disc here?
Yes, sir.
Okay. So once you hit the SAP, you go inside SAP, you are already inside the canal. And disc is here. The lateral part of the disc is here. Understood?
Yes, sir.
Yes, sir.
Okay. Because the facets are like this, inwards. It's not same like this everywhere. It's not straight. They're not straight. Here the facet is here. Okay. It is. The SAP is here. At this level it is here. At this level it is here. Okay. Understood?
Yes, sir.
So it makes a lot of difference. A 10 centimeter for L5 S1, L4 L5, maybe L4 L5, you are inside the disc. 10 centimeter at L2 L3, you may be here. You may be here inside the canal. Okay. This is same on MRI also you can see. On MRI also you can make out. Look at here. See the facet joint here. Okay. Look at the facet joints here. Look at the facet joint here. Can you see with the in relation to the disc?
Yes, sir.
Yes, sir.
Look at this. Understood now?
Yes, sir.
Yes,
Yes,
sir.
correct, sir.
Very clear, sir.
Clear?
Yes.
But this is like a L5S1 foraminal herniation with upward migration.
Upward down.
Okay. So for L5,
Yes.
you have to go far lateral, identify the tip of the spinous process, start from there. Okay. That is for the central one. But this is just a foraminal one. So we don't have to go that far lateral for L5S1 also.
Okay.
Okay. Just go
Okay,
into the
sir.
foramen, like foramen. Okay. Put it in the foramen. Look at this. Yeah, where is the working channel? Working channel is the foramen only.
Foramen. Yes, sir.
Even if some part is outside also.
Yes, sir.
Yes, sir.
Okay. And we can remove it from here. We don't have to go inside. There's no need. Everything is here only. It's a foraminal herniation. Right? We don't have to go inside all the time.
Yes, sir.
Now, where is this?
Foraminal herniation?
No, this is subarticular.
Subarticular. Oh,
Sir,
This is
Yes,
subarticular.
sir. Particular.
That means paracentral herniation. Right?
Paras.
Okay. So in this case, what
paracentral.
what we'll do? We'll go like this. Okay. We'll enter the disc here. Maybe at the mid particular line. At the mid particular line, we can enter. Okay. Put a scope here. Put a working channel here inside. Look at this. Where's this? Where's the opening of the working channel? At the subarticular level. This is midline, right?
Yes.
This is midline.
Yes, sir.
The working channel is here, and we can remove it from here. This is like a central one. You can see this. Almost central, right? So in this case, you have to go more angulation, maybe starting from here. And at medial particular line, we should enter the disc. Look at this. Can you see here?
Yes, sir.
This is the medial particular line. At the medial particular line, we are entering the disc. Because the fragment is here. That's why we have to enter from here. We have to put a scope here.
Yes, sir.
Understood? Now it is clear? Whatever we discuss, these are the examples of that. So this is what we see. I mean, we don't see, but we had to. This is the patient lies in the prone position. Okay, in the prone position, we have the foramen like this. This is lower part of the foramen. This is upper part of the foramen. Okay, and you can see this is the which root is this?
Exiting route.
Exiting nerve root.
And this one is
Traversing
Traversing.
nerve.
Traversing.
this
SAP.
SAP.
SAP, yeah.
and this is
And this is
Dorsal.
disc.
disc.
Disc, yes. You can see the bone here. You can see the bone here, and that is your disc. Okay.
Okay.
This is what we do. We go hit the SAP, and then in the lower part of the foramen, right? Always in the lower part of the foramen. Not here, never here. Not in the upper part. SAP is in the lower part of the foramen. Upper part of the foramen has inferior articular process. Where we enter? This point.
Yes, sir.
We hit the SAP, and then we walk off the SAP. Then we go inside. Right? So this is just a basically the magnified view of this part only.
Yes, sir.
So after hitting the SAP, then we walk off the SAP and then we go inside. Then whatever angulation we have taken, the needle will go according to the angulation what we have taken, the distance what we have taken, where it will enter the disc. Okay, then we have to check AP lateral to see whether you're inside the disc, at what level you're inside the disc in the AP view. Whether in the lateral pedicular wall, mid pedicular wall, or the medial pedicular wall. Okay.
Okay.
So this is a fluoroscopic view, endoscopic view, what we get. Okay. So the moment we go with our, we put our sleeve inside. Okay. Here's the facet joint, SAP over here. Superior articular process. And there's this is a disc over here.
Disc over. Yes, sir.
Suppose if it is a foraminal herniation, you will get it here only. Okay. If it is a paracentral herniation, you clear this part, you'll get a fat over pupillary fat, some vessels over here, clear those, get a good vision, and start going inside.
Okay.
Okay. So I'll show you some of the steps. Now can you make out some herniation here? Big herniation here?
Yes, sir.
Yes.
Yes, sir.
L4, L5.
Yes, L4, L5.
4, 5.
Is L4, L5. Herniation is there. Okay. So where is this herniation?
Where is the
So this is almost, I think, central one.
Central.
This is the taken from the center. Can you see
Center.
it? Because you can see all the bunches of the nerve roots are in the center. Okay.
Yes.
Yes, sir.
Okay. So they're in the center, and this bulge is here. But whether it is only central or it is paracentral also, we can see from the multiple images. This is extraforaminal area, right side.
Mm.
Yes, sir.
Now we are going towards the foramen. This is right foramen.
Yes.
Is there any bulge
Yes.
over here?
No.
Mm.
No, looks clear.
Now his root is very clear. You can
Yes,
see
sir.
orbital fat around. There is no
Yes.
compression thing. Okay.
Mm.
Now we start going towards the paracentral area. Now you can see there is some herniation over here.
Yes, sir.
Yes, sir.
Okay. So paracentrally
Mm.
there is some there. Now we go to the center. Now you can see the center.
Central herniation.
Part.
Yes, sir.
So this is more the
Yes.
central kind of.
Central herniation.
Okay. Now we go towards the left side. Again, left side is clear. Okay. Understood?
Yes.
Sir.
Yes, sir.
Understood.
And it is basically compressing the traversing root.
Correct.
What is this?
Uh,
Which root? Is this root?
Phylum terminalis.
No.
PL.
No. This is your PLL, posterior longitudinal ligament.
Oh, yeah.
Can you see this PLL here? Can you
Yes, sir.
see it here?
Yes.
See this,
Yep.
it is going
Yes,
like
sir.
this, and it is basically pushing the posterior longitudinal ligament.
Yes.
Okay.
Understood?
Yes, sir.
Yes, sir.
So this is what I'll show you. So what I'm doing is basically I'm what I'm doing is now this L4 L.
Yeah. You are inflicting local anesthesia?
No, right now I'm
Yeah.
just measuring the distance from the midline. So you can see the
Oh.
midline here. So this is with the
To
needle.
spinal
Yes.
process.
Because I know it's a central herniation, so I'm just measuring the distance. Okay, so that I want to go more lateral, far lateral. Okay. Now with this, after measuring the distance, this is the spinal 20 to 20 gauge needle through which I'm entering inside. I'm hitting the SAP over here. Hitting the SAP. Okay, I'm hitting the SAP.
Yes, sir.
Hitting the SAP, I'll check lateral where I'm hitting. Okay, before that. Okay. Now there are different techniques. Okay, some people, lot of people you'll see that way, what they do is they go for they put a marking over here, right? Central line, central marking
Spinal process.
over the spinal process. Then they'll go lateral.
Mm.
Okay, then they check the angulation of the disc and then put another marking over there.
Yes.
Okay, where it is crossing, that is the entry point, something like that, right? That is not required. What you can do simply is that you just paralyze the end plates. It will automatically take. If you paralyze the end plates, you have to go craniocaudal, right? Your CM will go craniocaudal.
Yes, sir.
Sir.
Yes, sir.
Target in the center, the needle will automatically take that angulation only. That is what you are doing in the lateral view also. You are basically paralyzing end plates, right? And then we are going perpendicular to that, parallel to the center of the disc. Okay, that you can do in the AP view also. So simply in the AP view, you paralyze the end plates properly, go for the centralization. Centralization is important. You should be exactly in the center. Okay, go for the paralyzation of the end plates and see the distance on the midline. Okay, understood?
Yes, sir.
Yes, sir. Understood.
Now start going like this. Okay, you hit the SAP. Once you hit the SAP, what happened? Okay,
Yes, sir.
see this tip here. See the tip here?
Yes, sir.
Yes.
So which part of the SAP we are hitting? The posterior,
Superficial part.
right?
Probably
The posterior part.
posterior part.
You know? This is
Yes, sir.
this is the ventral part, this is the dorsal part, right?
Dorsal part.
This
Yes, sir.
ventral part, this is dorsal part. So if you're hitting the dorsal part, that means you are slightly superficial,
Yes, sir.
right?
Yes, sir.
So then we have to
Yes.
change the angulation. Now we change the angulation and then hit the ventral part.
Deeper part.
Ventral part. Okay. Now can you see this? We are hitting the ventral part now.
Yes, sir.
Yes, sir.
Now after hitting the ventral part, now you have to walk off the SAP. Now see this, I'm just walking off the, just trying to manipulate. I came out, change the direction. You have to change the direction, right? So you have to come out a little bit, change the direction, and then you enter the disc. Now look at this. In the lateral view, I'm just entering the disc here. Can you see that?
Yes, sir.
Yes.
Okay. Now here I'm at the almost at the
Medial pedicular line.
particular line. Because I want to target a fragment which is in the center,
Central. Yes, sir.
slightly on the left paracentral area, which we saw in the sagittal sections. Oh, I forgot to show you that. Sorry, the axial image. Where are the axial image? Sorry. Can you see this? Axial images?
Yes, sir.
Yes, sir.
So this is what is happening.
Yes.
This is central bulging extending into the this one. See, this is extruded patella. Okay. Slightly
Yes.
going towards the paracentral area also here. Clear? Understood?
Yes, sir. Clear.
So this is
Yes.
the extruded patella in the center and extending into the paracentral area. Not going to the foramen. That's why the foramen was clear on both the sides, right?
It's 21 hours.
Okay. Now see, look at this. What is that?
Root.
Exiting.
Huh?
Exiting root.
That's the exiting root over there. Look at this where it is lying. It is so low lying exiting root. Right?
Yeah. Yes, sir. Yeah.
Yes, sir.
And this is the
Sir, is it in a dural space?
huh? What?
Sir, the exiting nerve root is take the contrast, isn't it, sir? And also dural space. So our needle is within the dural space, isn't it?
No. Suppose sorry. Suppose we are in the dural space. What will happen? Firstly, it will go to both the sides.
Oh, yes, sir. Yes, sir. Yes, sir.
Okay. Secondly, dural sleeve will come up to the foramen only. Whereas your contrast is going out of the foramen also.
Yes,
Okay.
sir. Yes, sir.
Yes, sir.
I think.
That's right.
Okay.
So that's why it's not in the dural space. But good, you asked that. Huh? What about? Anything?
No, sir. Clear.
Clear, sir.
So now what we'll do, we'll just go give some local anesthesia over the annulus. Epidural space will give local anesthesia 1% only, and the entire tract will do with this needle only. Okay. Now we'll use the this is the thicker introdistal needle. Now we know the direction, right? In the same direction we start going. You can see the how I'm using the bevel.
Bevel, yes, sir. Bevel is turning
Yes.
upwards.
Yes, because this time my needle is going in the upper part. Okay.
Yes, sir.
So what I'll do is we'll change the direction. You can see this. I change the direction, right?
Yes,
Now the
sir.
needle will go in the right direction. Okay. So this way you can use your bevel. Now I'm again hitting the SAP and we'll go inside the SAP. And now you can see here, just entering the disc. Okay. Enter more and we'll put a contrast. And you can see the contrast is inside the disc now. But where's the tip? Just in
At the annulus, at the
just
Just enter in the disc.
yes. It is just at the posterior annulus.
posterior annulus. Yes, sir.
This
También se me mueve y pedírselo bien.
now we are putting the guide wire inside.
¿Me vas a comer?
Huh?
Qué rico. Ay.
Okay. Now this is a guide wire. Okay. Now over the guide wire, we'll put our dilator.
Dilator. Yes, sir.
Okay. With this dilator, we check AP. Okay. We check AP. Now where are we right now? Where is the dilator now? Just
we are
At the SAP.
just at the SCP.
Yes, SAP. Just at the SAP. Now you can see this. We are just at the SAP over here. Okay. Now you have to be careful about your guide wire, because when you're putting a dilator inside, you may push the guide wire inside. Okay. So you should be careful about that. So once I enter the SAP, under the SAP, you can remove your guide wire. Okay. And then you can go inside. Now we are crossing the SAP. Now we enter the foramen. Right?
Yes, sir. Yes, sir.
Foramen now. Look at this. Now with this, I'm not going inside the disc. I'll keep it here only. Okay.
Why, sir?
Now we'll keep it here only. We don't want to go inside the disc with this.
Why, sir?
Huh?
Why, sir? As we pass the guide wire inside the disc, if I go inside out technique,
inside out, yes. For inside out, yes. But here we are doing for the extruded disc, right? We saw the extruded.
Outside in technique. That's why we are keeping the dilator outside the disc.
Yes, we are keeping it as foramen only.
Keeping in the foramen only. Okay,
yes.
Sir.
Because we don't want to go inside. We don't want to make a big rent in the annulus. Because our target is a fragment which is lying in the center here. From here to here it is trending. On MRI, we saw that fragment is from here to here. In the center, mostly in the center, but some part is also extending to the paracentral area.
Paracentral area. Yes, sir.
That is on the axial MRI, right? So what I'll do is I'll put it here only. I'll put my sleeve over here. Okay. We'll put our sleeve over there. So this is the sleeve which is going. Now remember this thing, the open end of the sleeve, when you're going inside, it should face upward because you have an exiting route here. This point should be downward. This part should not be upwards. the open part should be upwards. Understood? Because your exiting route is going like
Yes, sir.
this.
Yes, sir.
Yes, sir.
Bevel upwards, isn't it, sir?
Yes, the bevel open side is upwards.
Yes,
Look
sir.
at this. Can you see this?
Yes, sir.
Okay, so we can see this, the working channel. Now we are going over the guide, over the dilator. We are putting our working channel. The working, where is the working channel? Into the foramen only.
Foramen. Yes,
Foramen.
sir.
So when we remove this one, what will you see? We will see the SAP. Okay. So I'm removing the dilator. Okay. Now the scope is inside. Now with this RF, I'm just clearing the foramen. Can you see this? This is the foramen, right? This entire is the foramen. So we're just clearing the foramen. See that? So we are just clearing the foramen over there.
Yes, sir.
Yes, sir. Clear.
Now again I put the dilator inside. After clearing the foramen, I'll again put the dilator inside and I'll start going more deep inside now. See this? Now I'm going more deep. Now I'm targeting the, now through the scope, I'm seeing the fragment.
Fragment, yes, sir.
Okay.
Central part.
After clearing that, now here I'm changing the direction of the bevel.
Once you're inside the foramen, you can change the direction, sir.
Yes. Once you see that, once you see the scope that there's no root over there, okay, then you can manipulate this. But if that is only in case is required wherever you have a downward migration, because the patient was having slightly downward migration. So that's why we are slightly going downwards like this. But here you have to be quick because the nerve root is compressed over here. Okay, the nerve root will get compressed. Slight compression is okay for maybe for 15-20 minutes, okay. Okay, but if it is compressed for a longer time, patient will have paresthesia or the numbness after some time. Okay. So in the lateral view, when you see in the lateral view, when you look at the lateral view, our bevel will be facing towards the canal.
Bevel is facing outside, outwards, isn't it, sir?
It's facing backwards,
Backwards. Yeah, yes, backwards.
Okay,
Sir.
towards the canal. Towards
the canal. Yes, sir.
Okay. If it is purely central, in that case, you may advance further to cross the medial pedicular line.
Yes, sir.
Okay, sir.
Okay. So this is what we see when we, so after clearing the foramen, this was the foramen over here. After clearing the foramen, so this is the fragment I'm removing from the center. Can you see that fragment here? Okay.
Yes, sir.
So
yes, sir.
this area is the foramen area. This is the foramen area. Here's the SAP subarachnoid process. Here is the normal disc over here. Okay. And this is the canal. Now look at this. This is SCP over here. Here is the PLL, posterior longitudinal ligament.
PLL. Yes, sir.
Yes. And here's your annulus over here, disc over here. Can you see this epidural fat over here?
Yes, sir.
Which epidural
Yes, sir.
space is this? Anterior or posterior?
Uh,
Anterior.
posterior.
Anterior. Posterior is here, somewhere here. This is
Oh, yes.
anterior, because just above the disc. So this was, now you can start seeing the epidural space. You can start seeing the fat over here, because there was a big fragment over here which were removed. So once we remove this, see this. Once we remove this fragment, you'll start seeing the canal. This is the big fragment. You can see. Can you see the fragment is slightly pinkish?
Yes, sir.
Can you see that?
Yes, sir. Yep.
This is how the fragment, when it comes out, it causes severe inflammation. Okay, because this is nucleus material is highly inflammogenic. It causes severe inflammation. Okay, so that's why at times it becomes like this, comes out like a pinkish. And the moment we take out everything, now look at this. After removing this, see this. Now can you see the fat over here?
Yes, sir.
Yes. Yes,
That's
sir.
epidural fat, which was totally compressed. Okay.
Okay, sir.
So now I'm just trying to remove from the center. This is the central one. That's the central. The earlier fragment was which was in the paracentral area. Okay. Now after clearing that, now we are going more deep inside, and we are doing the central part. This is the central fragment. Okay. So this is another like a, now can you see this here? Can you see this big herniation here?
Yes, sir.
And look at this extension.
For
Huh? See, look at the extension of this.
Central, paracentral also.
Yeah, starting from here to here, it's going here, completely obliterated.
opposite.
Huh? What? Okay, so that's a big fragment over here, right? And you can see from the parietal section also. It's a very big fragment over here. Okay. So in this case, what we'll do? Again, same thing we'll do, because we'll keep the foramen, start clearing the foramen. From there, we'll start going inside now. Okay. But my needle position would be what? For the central one. Is this point clear? I want
Yes,
to remove this from the center. So my needle position will be as if I am removing this from the central herniation only. But I'll keep my dilator and the scope into the foramen only first. I'll start clearing from there, then I'll start going inside.
Okay.
The same thing we'll do here. We'll paralyze the end plates. Okay. After paralyzation, see this. Now we have paralyzed the end plates. This is what I'm measuring, the distance from the center. Go with this 20 gauge needle. Hit the SAP. After hitting the SAP, what we'll do? What is the next step?
lateral view.
Very good.
Lateral view.
So that's a lateral view. So where is the tip now?
Superficial.
It's very posterior.
Okay.
Yeah. So this is the dorsal part of the SAP over here, right?
Yeah.
This is ventral part.
Yes.
We are two dorsal. That means we are two.
Readjust.
Huh?
To change the direction.
Yes. So we are too superficial. Okay.
Yes.
We are hitting the SAP, but we are too superficial. After hitting SAP, this we are hitting here. We are too superficial here. So what we'll do? We go back. We go back, change the direction,
Change direction. Yes,
change the
sir.
direction, go slightly more deeper, and again check. Again we'll hit the SAP and we'll check. This time we are hitting the
Ventral part of the SAP.
ventral part of the SAP. Okay. Now I know that I don't have to. I'll just withdraw a little bit, change the direction, and we'll go walk off the SAP. Now again, where are we? In the posterior annulus.
Posterior annulus. Yes, sir.
We see this discogram,
Discography. Yes, sir.
and you can see this over here. This fluid material is here. We'll check AP. In the AP, my tip is in the
Medial particular.
medial
Pellicular 9.
Okay. So we'll come out. We'll give some local anesthesia over there. We'll give contrast here. Now again, you can see the exiting route here and the traversing route here.
Yes, sir.
Okay. Here we'll give some local. After giving local, washing out of the contrast. Now we'll go with this 20 gauge dilators, or sorry, introducer needle. Okay. Hit the SAP, walk off the SAP, and you enter the posterior part of the annulus. Check later AP. See this?
Middle pedicular line.
Middle particular line and the central line.
Central line. Yes, sir.
Central and middle particular line and the central line, because my target is completely here. And I know that I can go very freely over here because there's a big fragment over here which is pushing the dura upwards. So there's no dura over here, there's no nerve root over here. I can go safely. Okay. Now put a guide wire. Put a guide wire. Yes,
Sir,
please.
can I interrupt
Yeah, please,
for
please.
a while? Sir, can you just could you please show the contrast part of the dural area? Yeah. Sir, as we giving the contrast and seeing the both exiting route, and where is the traversing route? Is it push medially?
Here.
Yeah. Oh, okay, sir. Okay, sir.
Yes,
It seems like still it is in the its own area.
Yeah. No, it is pushed up backward, no, backwards.
Okay, sir.
Pushed
Okay, sir.
backward.
Yes,
Not
yes, sir.
medially, but it is pushed
Now I
backward.
understand. Yes, sir. Thank you, sir.
So, no, but you must clear this point because I'll show you so that you'll understand with the MRI, you'll understand. See that. Okay, so we went like this inside. We reached here, but we are going safely here because we are in the canal.
Yes, sir.
We know that there is a big fragment here. The nerve is pushed backward over here. Here somewhere is a nerve. We can't see that, but here somewhere is a nerve.
Yes, sir.
The root is somewhere here. The dura is pushed here. Okay, so we can go safely inside. Understood?
Okay, sir.
Because we know
Yes,
there is
sir.
no nerve root, there is no dura here. Okay.
Yes, sir. I understand, sir.
Okay. Now look at this. But this open part is what? Where is this open part? It's looking towards the
the disc upwards.
upwards, not towards.
Upwards.
It's looking upwards.
Yes, sir.
Towards the canal.
Canal. Yes, sir.
Okay. See this. Where are we? I'm not here. I'm still in the foramen because I want to first clear the foramen.
Yes, sir.
Okay. First, we'll clear the foramen. Now, see this. We are clearing the foramen over there.
RF machine.
Yes.
Yes, sir.
Now, after clearing that part, now we'll put again the dilator inside. Okay. And now we'll go more deep. Now you can see where I'm now. See this, right? Yeah.
No problem.
So now we are looking at the central part. Now our scope is looking at over here, this entire part. Okay. After clearing this part of the foramen, now I entered more inside to see the big fragment over here. Now our scope is, this open part is here. The scope is looking at the fragment. Now this is the fragment over here. That is it is so much stuck over there. Now I am rotating it completely. दर्द नहीं हो रहा अब दर्द नहीं हो रहा ठीक है ना बस अभी दर्द कम यार फटाफट जल्दी करो so I'm just asking this guy that if there is a pain now because when we extract this material it is almost stuck to the nerve roots and the dura. Okay, so you have to be very very careful about that also whenever you're removing it. Okay, you have to remove it gradually. So see this, I can see that I'm holding this fragment but I'm not removing it. I'm holding that fragment but I'm not removing it because it is stuck to the dura and the nerve roots. So you have to gradually rotate it so that the dura will start leaving it. Okay.
Okay, sir.
So that is only possible if you are in a local anesthesia, if you do it in a local anesthesia.
Yes, sir.
Oh. दर्द नहीं हो रहा अब दर्द नहीं हो रहा ठीक है ना बस अभी दर्द कम यार फटाफट जल्दी दर्द करो 1 मिनट रख लो पैर को मोड़ करो और नीचे हमारा है लगा रहा है
Oh, it's a huge fragment, sir.
Huh? Yeah, it's a huge fragment. You can make out on
Huge.
the MRI, na? It's such a big fragment. So this was the central one. This was the central. Now you can see here. See, after removing the fragment, now see this, the entire space is empty now. Can you see that? This is the PLX one. Okay. This entire space was filled with the fragment. That is completely free. Now this is a case of L5. As L5 is slightly transforaminal, it is slightly challenging. Okay, because you have a what is there? Iliac crest.
Request.
Now look at this. There's a subarticular herniation over here. And look at this nerve root. Can you see that nerve root here? Okay, this is the right side, this left side root is compressed over here.
Push.
Okay. So here you can see the central midline over here. Okay. Now you have to avoid the iliac crest. So you have to take this angulation for L5S1. Same. We'll go inside. This is SAP. See how far it is. It's the SAP from the midline. Right? We hit the SAP. Walk off the SAP. Check in the lateral. We are just entering the disc over here. Discogram. Put a guide wire inside. Over the guide wire, then you have to put a dilator. Then this is working channel here into the foramen. Okay. And from there we are extracting it. So in the alpha S1, you have a challenge to go inside. Okay. You can go into the center to the foramen, but beyond that it becomes difficult because if you try to go more, you will hit the what? What will hit? End plates.
And blades.
Okay, you are going in the angulation, na? So suppose you are going in this angulation in the atlas level, what will happen? You will hit the end plates, right? Yeah. The same because here, because of this angulation, it's difficult to go more deep inside.
Yes, sir.
Keep it as foramen and try to remove it from there. So if the central herniation is there, it becomes difficult to remove from the vidna in this case. If it is purely central. If it is central, extended to the paracentral, you can remove it from there. You can extract it from there. So this is what I saw that in the foramen. This is the foramen. You can see the foramen. Some part was extending into over there. And this is what we have removed it from there. The fragment there. This another, you can see here, there's a L5S1. Can you see the big fragment over here? Slightly migrated downwards also. See at the disc level, it is not much, right? But at the lower level, it is a big herniation here. So this is a slightly downward migrated disc.
Subarticular.
Subarticular, yes. Same thing we'll do. Okay, so midline, just above the ilium. Just above the ilium. Okay. Hit the SAP. Go inside. Do the arthrogram, discogram. Check lateral. Here is the posterior annulus over here. Dilator. Working sleeve. And now we start extracting from there. So you can see here. See, there's an angulation. That's why it is, the SAP is here. Okay, we are seeing it from the angulation, right? We are seeing it in the angulation. So here is the, here somewhere is the end plate. The superior end plate is here. Inferior end plate is here. That's the annulus. And that's the canal here. This is the SAP, superior arterial process. Okay, and we are in the foramen only. In the foramen, we are seeing this, and there's extrusion material over here. Okay. We will start seeing inside. You can see the extrusion material over here. Space. Space. Here's the magnetism. You can see that's going over here. Yes. Can you look at this? This all does the downward magnetic disk. After clearing the foramen, you start going inside and we'll remove the extruded material from there. So patient will have this kind of pain when we extract this fragment, but immediately after the, once we remove that, patient will feel so happy that they don't mind this pain for few seconds. So clear, everything's clear about the steps. Any doubt?
Yes, sir.
Yes, sir.
Okay, good. So we must know about the complications. Okay. For any procedure, complications are also important. We must know how to deal with them. So nerve injury at the time of entry is very common. But if you follow the steps, what I'm telling you, if you know the anatomy, if you know the MRI, if you know the fluoroscopic anatomy, you'll be able to avoid many complications. Second important thing is, this is the safety feature of doing it under local anesthesia. I do it 100% under local anesthesia. That is one of the safety feature. If you give proper local, if you use this technique, what I've told you, patient will not have much pain. Okay, patient will be comfortable throughout the procedure, except at the time of extracting that fragment. Okay, but that is also important pain, very useful pain, because that will tell us that yes, patient is having pain, so it is stuck somewhere. So we will be careful. If the patient don't feel pain, if you start to remove it suddenly, they may cause dural tear also. That may damage the nerve also. Okay.
Okay, sir.
Post-operative dysesthesia is possible because when you put a sleeve inside, now this is mainly to the exiting route, because when you are in the foramen, it is not the traversing route which is compressed. It is the exiting route which is compressed. Now suppose we are doing it for the L5 route, which is compressed because of the disc herniation. Patient may have a good relief with L5, but patient will say that my pain has changed, pattern has changed. Earlier I was having in this area, now the pain is not in that area, that is fine, but this is another area which I'm having numbness or the pain. That is because of the exiting route. Okay, so you have this much space only where we have traversing to exiting route and the traversing route also. Okay, as we go up, the size of the Camden's triangle is very narrow. So it will be very
Yes.
quick. If you're doing something at the L2, L3, L1, L2 level, you have to be very quick because you will compress the exiting routes over there. Okay. So this is the part of the, fortunately it is lies in the upper part and we are working on the lower part. At times, if the fragment is pushing the nerve, so at times these coronal sections are also important. Coronal sections will tell you where is your exiting route. Now suppose if you are doing something at L5 is fun and there's extrusion over here, it is pushing the nerve upwards and we come like this, we may be encountering the exiting route. This has happened with me. I was trying to enter inside, but every time I was touching the exiting route. So I had to abandon the procedure. Then I checked it on the MRI, and then I could make out, yes, it is because of this. Fragment was pushing the nerve towards outside, and that's why I was getting the nerve everywhere. Whenever we have a upward migration, upward migration, you have to take an angulation upwards. Okay. In that case, you'll be compressing the nerve root. You're clearing the exiting route. Already exiting route is compromised. And you have to put your working sleeve and scope inside. Okay, so there is a good chances of paresthesia, dysesthesia after the exiting route approach. Traversing route injury, if you do go too medial, if you not enter the disc and you cross the middle border pedicle, okay, and you not enter the disc, there are chances that you may hit the traversing route. But again, you have to see that your fragment, if the fragment is pushing it backwards, sidewards, then you are safe. The reherniation is possible. The most important feature what we must advise to the patient is that they'll have to take all the precautions for at least 4 to 6 weeks. Whatever precautions they were taking, they'll have to take all the precautions. Okay. We usually advise them to wear a belt, LS belt, lumbar support belt for 4 to 6 weeks. Explain them outside. There is a small incision which will heal after 7 days. You may not see anything. But inside, when you are removing everything from there, it takes around 4 to 6 weeks for the healing. Okay, so during that time, they must wear the belt. always, except while sleeping or while having their food. Okay, it's not that LS belt is going to support too much, but LS belt will remind them not to bend suddenly, not to lift weights. That is why. Because immediately after the surgery, they feel so comfortable. They think that everything is fine. There's nothing because outside skin incision takes 5 to 7 days to heal. That's it. And they don't have anything. But they should understand, and we should understand that the inner annular, when we remove the material from there, that takes some time. And that is more possible when you do aggressive disc clearing with annulotomy, when we open the annulus. So there are good chances that there is a chances of reherniation, which are less common with sequestrotomy and fragmentotomy, because there we are not going inside the disc. We are not we are not damaging the annulus at all. Okay, we are just targeting the fragment. So the patient comes to you with the maybe after 1 week, 2 weeks, 3 weeks, 4 weeks, whatever it is, or 2 months, patient comes back to you with a severe radicular pain. You must go for the contrast MRI. Okay, don't just order simple MRI because you have to rule out other thing also. The most common is your discitis. Yes, abscess or discitis. Okay. So we must go for the contrast MRI. So if the discitis happens, spontaneous disease is less likely. Also, neuroplasty may help in reducing the inflammation. Revision surgeries for the bleeding or the dural tear. But discitis is more, sorry, the dural tear. What is? Where is? This is important compared to the Percutaneous dysplasias. It may present early, and response is also better. Percutaneous dysplasia, when you do percutaneous disc procedures, in that case, since we are not disturbing the outer annulus, if the infection is happening inside, we may not come to know. Because till the time the infection reaches to the outer annulus or to the end plates, it is not painful. We will not come to know. Once it reaches outer annulus or the end plates, then only patients will start feeling pain. By the time it takes around 3 to 4 weeks also. It is already spread inside. So those patients respond poorly to the antibiotics. So you have to go for the long-term antibiotics. These are the protocols for the antibiotic regime. That depends on the hospital to hospital also. Vascular complications, they do happen. Bleeding from the veins, epidural veins is very common. Every case we'll have some bleeding from the epidural veins, but that we can easily coagulate with the RF. Arterial bleeding, at times it may bother you. Some small vessels are there, arterial vessels are there. They will keep bothering you. If it is you are unable to control it with the radio frequency with the coagulation with RF. What you can do is you can just change the direction of your bevel. So suppose the bleeding is happening from this side. If you see that bleeding is happening from this side, okay, you can just change the direction of the bevel like this. Okay, and wait for 2-3 minutes. So it will compress the arterial vessel over there. And it will block the vessel. Okay. There are some aberrant vessels are there, which are normally not there. Some big arterial vessels are there. They become some at times, though rare, but if this happens, it becomes very difficult to control this bleeding. Because the moment you cut this, the ends of these go behind the bones. They go inside and they start bleeding from there. Because of the retraction of these arteries, no? They retract inside and they start bleeding from inside. And you can't see anything. Because arterial bleeding, you can't stop with the pressure. It will keep on bleeding and you can't see anything after that. In that case, you just have to close. You just have to close. You don't have any other option. Just close it, observe the patient, don't discharge the patient, keep observing the patient. If required, go for the CT scan to see the hematoma formation inside the canal. If the patient complains of some numbness or in the legs, in that case, you have to go for the open surgery immediately. Though it is not required, like this is theoretical, never seen this. I have encountered one arterial bleeding like this, but it stopped automatically, gradually. I kept seeing with the ultrasound, we kept checking, but nothing happened. There was no hematoma. ICP, intracranial pressure, may increase. We discussed last time also about this because of the fluid pressure, what we give. So keep telling patient is awake. If your patient is awake, they will keep changing their neck position. Okay, they will complain of neck pain, but most of the time this neck pain is because of the posture. But don't ignore that. Don't ignore that. Okay, ask him to change the posture of the neck. If he's comfortable, it's okay. If he says, no, I'm not getting any relief in the neck pain, that means it could be because of the high intracranial pressure, because of the epidural engorgement. Bowel injury may happen if you go too deep inside, if you are not sure about your depth, you may injure the bowel. Okay, so with the definitive procedures, complications are going to happen. Be ready with that. Prepare yourself for that. Manage them. They do happen. You have to manage them. Not managing complication is a negligence, remember. Whenever you have any complication, document it. Document it. Always. Write it down. Accept it. That this has happened. That is not acceptance. That is actually that you have detected a complication. If it has happened, complication may happen with any surgery. If the complication has happened, you have detected it, you have started managing it, nobody can punish you. But if you ignore that complication, it becomes a negligence. Okay. Study each case and prepare yourself properly. Study each case means patient's history, condition, examination, MRI, correlation, very important. And plan your entry points properly. Don't be afraid of editing and learning. Keep learning, keep adopting these techniques. Okay, so that is all from my side. Any questions?